Good evening, everyone. My name is Elyse Olesinski, and I'm very excited to be sharing my Keystone project with you today. The topic of my project is how to overcome Venetoclax resistance in acute myeloid leukemia. Now, you might be asking yourself, what is leukemia? In my blood and in your blood, we normally have red blood cells and white blood cells that circulate around our bodies, delivering oxygen and nutrients to tissues and eliciting immune responses against pathogens. But what if suddenly these cells stopped working? You might find yourself fatigued, with unexplained weight loss, or anemic. You might bruise more easily, and over time, find it increasingly difficult to breathe. In leukemia, white blood cells grow too much, and they suppress the production of normal blood cells and crowd out healthy ones. The symptoms that I just described are what 1.8 million people worldwide face every year, 10% of all cancer cases. Within that 10%, there are numerous different kinds of leukemia, but a particularly aggressive one that warrants our attention is acute myeloid leukemia, or AML. In this disease, myeloid stem cells fail to differentiate into normal blood cells, but they continue to grow uncontrollably and crowd out healthy ones. In the United States, about 21,000 people are diagnosed with AML annually, and the mean age of diagnosis is 60 years old. So it is definitely skewed towards older adults. The current standard of care therapy for this disease is intense chemotherapy in order to kill the cancer cells and stem cell transplants in order to replenish the body with healthy ones. But the majority of patients are too old to complete their chemotherapy cycles or will still relapse. So there's a great need to identify new therapies that are more tolerable to older patients and more effective in yielding sustained remissions. Very excitingly, in November of 2018, the FDA approved the groundbreaking drug Venetoclax for the treatment of AML in combination with standard of care drugs. And this has since changed the landscape of how we treat the disease. Venetoclax is a very well-tolerated drug, making it ideal for older patients who cannot endure traditional intense chemotherapy. And what we've seen from clinical trials is that 69% of patients on Venetoclax will go into a complete remission for a mean of 16 months. For a disease that previously had a median survival for patients older than 60 of 2 to 4 months, and only about 6% of these patients alive after 2 years, Venetoclax is a game changer. But despite all the positivity that the drug has generated, with any new therapy, there are going to be patients who are inherently resistant or who will develop resistance to the therapy over time. Although patients did fare very well on Venetoclax, the majority of remissions were not sustainable. And so this tells us that there is still a lot of research that has to be done in order to combat AML. So the goal of my project was to identify what other drugs are effective in the Venetoclax resistant setting. Specifically, what drugs can effectively treat patients for which Venetoclax is not an option. In my lab, we developed a novel cell profiling assay, which is a test that can tell us what drugs push cancer cells closer to the threshold of cell death. A metaphor that I find convenient to understanding this assay is this cliff. Cancer cells that are far from the threshold of cell death are harder to kill, or unprimed, while cancer cells that are closer to the threshold of cell death are easier to kill, or primed. Our cell profiling assay, called dynamic BH3 profiling, tells us which drugs make the cancer cells primed, or close to cell death, and then by extension, whether they may be effective therapies. For this project, we made leukemia-bearing mice resistant to Venetoclax by treating them continuously with Venetoclax until they relapsed. Then, we screened 40 drugs in 5 Venetoclax-resistant AML models using dynamic BH3 profiling. In the plot that you see, the large red dots represent hits, or drugs that made the cancer cells close to cell death. These are the drugs that may be effective against Venetoclax-resistant leukemia. Based on these red dots and partnerships that our lab has with a sponsoring drug company, we selected 4 drugs: S63845, LCL161, birinapant, and quizartinib to test in mice. All of the drugs that we chose are different types of protein inhibitors that, when used, disrupt cell signaling pathways and promote cell survival. The first drug that we tested was S63845. Based on the literature, we chose to treat mice with both S63845 and Venetoclax at 2 different dosages. Those are the 2 combinations that you see in the graph above. When the mice were treated with S63845 and Venetoclax together, we found a statistically significant reduction in the percent of cancer cells in the mouse's blood compared to the untreated mice. But you might be asking yourself, why treat a Venetoclax-resistant mouse with Venetoclax? Interestingly, we found that the combination of S63845 and Venetoclax produces a synergistic response due to the respective proteins that each drug inhibits. Alone, neither drug is very effective against Venetoclax-resistant cancer, but together the drugs work to knock out 2 major proteins involved in cell growth and cell survival, and this explains why they worked so well together. The second and third drugs that we tested were birinapant and LCL-161. Similar to S63845, both drugs produced a statistically significant reduction in the percent of cancer cells in the mouse's blood compared to the untreated mice. We also observed that the durability of response to birinapant at 70 days was greater than that of LCL-161 at 35 days. Seeing efficacy from these 2 drugs was particularly exciting as well, because it demonstrates that there are still single agents that can be utilized in Venetoclax-resistant cancer. This can be useful in establishing 3rd and 4th line therapies for patients who fail initial treatments. And lastly, our 4th drug that we tested was quizartinib. As with the 3 previous drugs, quizartinib showed a statistically significant reduction in the percent of cancer cells in the mouse's blood compared to the untreated mice. It is another single-agent drug that is effective in the Venetoclax-resistant setting. But most impressively was the fact that it suppressed the cancer far longer than either birinapant or LCL-161 did. For quizartinib, mice stayed in remission for a remarkable 323 days. For these types of mouse experiments, seeing a response for 3 months is very good. So to have a response for almost an entire year is truly a phenomenal result. Seeing such a sustained response makes us optimistic that achieving longer remissions and even potential cures may be possible. And so what we ultimately take away from these experiments is very exciting. Not only did we identify 4 drugs with anti-leukemic activity in the Venetoclax-resistant setting, but we also validated our assay, dynamic BH3 profiling, as a predictive biomarker for disease response in relapsed AML. With leukemia being a heterogeneous disease and variable patient to patient, it is increasingly important that we have tests to help tailor our therapies to each person's unique disease presentation, an approach that is commonly known as personalized medicine. Dynamic BH3 profiling allows us to take cancer cells, profile them, and then determine what therapies may be most effective. It is a technology that is still in its infancy, but it may have the capacity to propel cancer treatment to newer productive heights. As a prospective oncologist myself, I'm very enthusiastic and optimistic to see where that may take us next. And so for my ultimate project, I chose to write an academic abstract and designed a conference-appropriate poster to present my research. Also, in collaboration with my lab, we have written and submitted a manuscript for which I am the 3rd author to the journal Cancer Cell, and that is currently under review. Lastly, I would like to thank everyone who made this project possible over the last 2 years. I would like to thank my lab team at Dana-Farber Cancer Institute and Harvard Medical School, specifically my principal investigator, Anthony Latai, and my mentor, Shruti Bhatt. I also want to thank Dr. Hansen from the biology department for being an incredible Keystone advisor. And I want to thank Boston University and the Kilachand Honors College for supporting my project. It has been such a pleasure being part of this program for the last 4 years, and I know that I will be propelled into my future because of my experiences in this program. I thank you all for your time and attention, and I look forward to any questions that you may have.